My name is Michael Jaff. I'm a vascular medicine specialist from Boston, Massachusetts, joined by three experts to discuss clearly one of the most innovative strategies for a disease that I've seen in my entire career. And that is the concept of delaying the progression of growth of small to mid-sized abdominal aortic aneurysms. Something that's been tried with pharmacologic agents in the past with absolutely no success, and now a signal that we might actually be onto something. So Andrew, you presented some 2-year first-in-human data on the Nectero East system for delivering PGG into small to mid-sized aneurysms. Could you just give us some summaries of what you presented today?
Yeah, sure, Michael. It was very exciting to present this data at Charing Cross today. So this was the first-in-human trial using the Nectero system, which includes a delivery system to deliver the PGG into the aortic aneurysm wall. The first-in-human study was performed at multiple sites, including Ramon's site and our site in Auckland. And it was 46 patients. And obviously, we used their 1-month CT after treatment as the baseline, and then monitored aneurysm growth over the next 2 years. In fact, they'll be till 3 years, but today we had the 2-year data. What that essentially showed was that the aneurysms grew 2 millimeters over 2 years, so 1 millimeter per year. To put that in context, the average size of these aneurysms was around 43 millimeters in diameter. And based on some previous trial data, we would have expected those aneurysms to grow significantly more. In other words, at least 60% more. And so this is really the first time, and as you say, medications have failed, but the first time a treatment has managed to significantly reduce the rate of aneurysm growth.
So just so that I'm clear, Andrew, the 1-year data had previously been presented. That was pretty exciting.
Yes.
So now the 2-year data continues to show a prevention of progression of growth to any degree even close to what we would have expected with the natural history. Was there any increase in growth from year 1 to year 2 beyond a millimeter, or was it still very impressively low?
Very impressively low. I mean, the growth at 1 year was around the 0.8, and at 2 years was 2. So really, we're not really seeing any significant change in the rate of growth. Really extraordinary for a single one-off procedure compared to, say, medication needing to be taken for a long time. So really, it was a very striking and pleasing result.
Let's stick on the medication story for a second. So throughout my career, there have been glimmers of hope. Doxycycline over many years has been talked about. That's been shown summarily not to work. Metformin, more recently, not shown to work. How do you put in context what's been accomplished with these 46 humans with one administration of PGG to those failed trials?
Interestingly, we look at 3 growth patterns with aneurysms: rapid growth, fast growth, slow growth, or minimal or no growth. What we've seen with those failed trials is 30 to 40% of the patients have rapid growth, about 40 to 50% slow growth, and a smaller percentage with no growth. With Nectero, what we've seen is that rapid growing cohort has dramatically dropped and shifted to the no growth cohort, something we've never seen before. So it's really reduced those rapid growing aneurysms, taken them right out of the equation.
So clearly PGG is doing something markedly different than any oral agent that's been tried in the past.
Absolutely.
So, Dr. Lee, earlier we also heard from Dr. Holden some very interesting data around the neck of these small aneurysms that seemed to me pretty interesting. I wonder, what's your thoughts about this delay in growth of the neck over time?
Yeah, I think that's probably just as surprising to the investigators as probably the audience as you hear that. I think we all know the proximal neck and problems with the neck is sort of the Achilles heel of standard EVAR. And in fact, proximal neck issues or growth of the neck leads to problems with reinterventions, long-term outcomes, SAC regression, success of standard EVAR. And so I think that if we can find anything that allows while aneurysms are being surveyed or watched or not treated, that the proximal neck doesn't further degenerate, that's a positive thing. And that likely, even if down the road there's continued disease progression that forces some more aggressive intervention, if there's a signal here that the proximal neck doesn't progress at the same level, it probably allows a slightly simpler or more routine repair that probably will be more durable long term. So I'm super excited to hear more about some of the proximal neck data, and I'm happy that you all decided to submit this for the vascular annual meeting in Boston, where then we're going to hear about some of the more specific proximal neck data. That'll get people that treat aneurysms really excited about any treatment that we can slow down the progress of any worsening aneurysm disease.
Great, thank you. Dr. Varcoe, what do we know about how PGG actually delays the progression of aneurysm growth and maybe even this stabilization of the proximal neck?
Well, we know quite a lot, Michael. The drug PGG has been around for quite a while. And we know quite a lot about the way aneurysms form. It's a degradation of the extracellular matrix proteins, specifically elastin and collagen. And that occurs because of enzyme activity in the blood vessel wall, MMPs, which do break those elastin molecules down. The way that PGG works is it has a very high affinity for binding with those fractured elastin molecules. It forms hydrophobic interactions, then hydrogen bonds, and over time, when it's exposed to reactive oxygen species, it forms durable and strong covalent bonds. So that's one mechanism of action. There are actually two others as well, though. It binds directly to the MMPs themselves and hinders then ongoing enzymatic degradation that can occur through that. So that slows that process. And it's also a powerful and potent antioxidant, which means that it reduces the inflammatory cytokine cascade. So throughout all of that, it stabilizes the whole aortic wall, creating a stable environment, which hinders aneurysm growth.
And it sounds like we actually know that when you administer one dose of PGG through the Nectero system, the drug, although given to the inner lining of the abdominal aortic aneurysm, tracks proximally and even distally. Is that your understanding?
Yeah, it's highly lipophilic, which means it penetrates through the aortic wall, and it also diffuses proximally and distally, which is, getting back to what we're talking about with the aneurysm neck, incredibly important. It stabilizes that neck component, which we know reduces future reinterventions and endoleaks.
I'd also say that as someone who's spent his career in vascular biology, the pleiotropic effects of PGG are particularly interesting because inflammations become a big deal in the pathogenesis of atherosclerosis in general. Matrix metalloproteinases are really the enemy of atherosclerosis development. And so there are some really interesting confounders in the PGG mechanism that could have much broader applications.
Absolutely. The sky's the limit, because as we know, it's not just aneurysm formation that relies on inflammation and the inflammatory cascade. It's atherosclerosis, the number one killer out there.
So Nectero is running an IND, randomized clinical trial. Obviously, it's enrolling quite well. We're excited about this because, of course, the question we always get, like we got earlier today, was, well, what about the control arm, right? What happens to the control arm? So maybe, Dr. Holden, can you give an update on what's the status of that trial right now?
Sure. So it's a trial, obviously, in subthreshold aneurysms, and in fact in 3 different size cohorts, so 3 groups, so we can see if there's any particular size of subthreshold aneurysm that responds differently, better or worse. It's a 400-patient prospective randomized trial, randomized 1-to-1, the control arm obviously being watchful waiting and the treatment arm being with the Nectero system, and then with regular CT follow-up. And the primary endpoint is really an event-driven endpoint. So, and those events are aneurysm-related mortality, aneurysm rupture, aneurysm reaching a threshold requiring treatment, either surgically or endovascularly, or aneurysms at the threshold, even if they don't get that treatment. So that kind of composite of event-driven thresholds is how we're going to differentiate. Obviously, there's an important secondary endpoint, and that is aneurysm growth over time.
And how's the trial enrollment?
Going very well. We're very pleased. It's about 40% fully recruited at the moment, and there's a lot of energy in the recruitment sites. It's going very well.
Yeah, what excites me about that trial is that it's very rigorous. There's nothing left up to the investigators after they open up the envelope and see what arm they're assigned to.
Yeah.
The core lab data is independently adjudicated. All the clinical events are independently adjudicated. So I think the rigor of the trial will stand on its own. And so, Ramon, what do you think we expect to learn from this large prospective multi-center randomized trial that has the potential to change the way we think about abdominal aortic aneurysms?
Well, obviously, we'll learn how this drug performs and whether it truly is efficacious. That's one thing. I think we'll also learn about aneurysm growth in the control arm too. We've spoken a bit about the historical controls we've been using, but maybe that's changed with modern medical therapy and smoking cessation. So I think we'll learn a lot about that as well.
Yeah, very exciting. So in the last couple of minutes, I'm going to ask each of you a very simple question, and I want your straight, pithy, honest answers. So I'll start with you, Jason. Let's say the trial's positive and PGG gets marketed safely, it's proven to be effective, it gets regulatory approval. How will this change your practice, not only your practice, but your partners and your referring docs?
Yeah, I think that if there is treatment for a small aneurysm beyond, hey, we'll see you back in 6 months and get some imaging, I can tell you that certainly in the Bay Area, where everybody's trying to find the fountain of youth, live a little longer, find some extra, sauce to be around a little longer. Hearing something that's scientifically proven to sort of impede progression of disease and a significantly positive thing. We would embrace it just as a group that sees a lot of aortic disease and takes care of a lot of young people with connective tissue. I mean, these would be the questions that I've had.
We don't have enough time to talk about the myriad of things I want to learn about this drug once they get their approval, for sure. How about in Australia? What do you think the impact of this therapy will have for your practice, your colleagues, your referring docs?
Well, what I've noticed, Michael, as part of the trial is how enthusiastic patients are to go onto some form of active treatment, because at the moment, this ongoing surveillance that we use gives them a lot of anxiety. And whenever I've looked at enrolling patients, they've grabbed the opportunity with both arms, both hands, and taken it. So I think we're going to end up, once we prove it's efficacious, I think we're going to end up doing this in a lot of patients.
Great. Andrew, finally, your perspective and wearing two hats. First of all, as a clinician in New Zealand, how do you think this would impact your practice? But secondarily, you've been involved in so many first-in-human trials. Put this experience in context from an impact potential.
Sure. I think on the first, I think it represents a paradigm shift in care. And I think the implication is going to be quite often these subthreshold patients with subthreshold aneurysms get sent back to the primary physician and get your scans, and we'll see you if and when you meet you get the threshold. But the onus now is on us to build those relationships. And I agree with Ramon. Most of the patients that we see, they're very enthusiastic to have an option, make a decision. Quite a small percentage of all the over 150 first-in-human trials I've done, I've felt represents a real paradigm shift in care. I've been lucky to be involved in 2 or 3, but this is definitely one of them.
We're certainly excited to see the outcomes from the trial, and thank you all for this great discussion.